They're telling me to hold it closer. All right. Good afternoon, everyone. I'm Jessica Lucas with the Aspen Institute. Thrilled to have all of you with us today. We are having a panel with Mount Sinai Health Systems. For 13 years, the Mount Sinai Health System has been a partner of the Aspen Ideas and the Aspen Institute. I want to acknowledge Dr. Ken Davis, who is here with us, former CEO, and also now an Aspen Institute trustee. Thank you, Dr. Davis, and your wife, Bonnie. As I mentioned, they have long been our partner and are really our anchor voice on all things health-related, bringing us into conversations each year about emerging technologies and how that can help us live longer and live better. Of course, one of those is artificial intelligence. It's here to stay, and typical of the Mount Sinai Health System pioneering system, they are the first health system to develop a AI in human health department. So they really are on the leading edge of this, and together we are with Dr. Brendan Carr, CEO of Mount Sinai, who's going to take us into this conversation. Thank you, Dr. Carr.
Thank you so much. I don't know if this is on. There you go. I'll also add my thanks to Ken for spearheading the partnership with Aspen, and I'll thank Aspen for allowing Mount Sinai to be a close partner for so many years. So we're lucky today. This is an exciting panel. As you heard, we're pretty proud of our history of being on the cutting edge. This is the chair of that first Department of Artificial Intelligence within a medical school. We also, just a month ago, got a lot of press for being the first medical school to issue ChatGPT to all of our medical students, which, if you're my friends, they're terrified because they're convinced now that means that their doctors aren't going to learn anything. They're just going to Google everything. But if you're us, you think that it's inevitable that they're going to interface with artificial intelligence, and we ought to train them on it as early as possible. So I'm not going to spend a lot of time introducing the panel because their bios are in the app, but I'll tell you the backstory on them. And the backstory on them is I started with Girish, who chairs that Department of Artificial Intelligence, and the idea that, that's really helpful. The Department of Artificial Intelligence inside of a medical school really opens up freedom for us to think about where inside of human health we want to have AI and how we want to think about it. So you'll hear obviously from him. I'll skip one and say that Lisa Stump is I almost didn't say this when we were prepping, a pharmacist first, but also is our data and informatics information lead for the health system. So she's the boss of all the data. She and I align on making sure that we have one source of truth of data. That's important to us as we run our operation. She's a relatively recent addition to the health system and is very forward-leaning in thinking about what human health is going to look like and the intersection of artificial intelligence is going to look like. So bookending Lisa on both sides are our doc-nurse partners that are driving into our operational environment and partnering with the innovative community, the intersection of technology, external partnerships, artificial intelligence, and human health. So we're really proud. We think it's really fun. I guess I just want to say a couple more grounding things. For those who don't spend time thinking about the ethos of an academic medical center, it's important for me to ground you in that and to say that in our DNA is to always be thinking about discovery, always be thinking about the basic scientific research all the way through to the pointy end of the spear where we're making a decision with you about your health. And that's an enormous strength I think, of the full thickness portfolio that we have. It means that we have the freedom to ask you, because we have a relationship with you, can we try new things? Right? Can we start to use information or to start to use artificial intelligence in a way that is helpful, that shapes your experience of care? And when we talk about that relatively simple concept, always learning from what we're doing, we call that a learning health system. We're always learning. Everything that we do is connected. And the reason we're here talking about artificial intelligence today is because it's the glue. It is the thing that is helping us to now. It's a tool, right? It's not everything to everyone, but it is everywhere, and increasingly we know that. And so it's a tool that we are all using to make sure that we translate that basic science research, translate that delivery system preference that you have into healthcare delivery. So I find frameworks helpful, and I'm going to share, and we don't have a perfect one, by the way, for how AI intersects with healthcare. But this one is helpful for me because I have a linear brain, and I like to think about things, in sort of concrete terms. I'm just going to give you 4 big domains. There's the administrative side, what Lisa famously calls
Back office.
Back office, right? She talks about the back office to the bedside. There is obviously the research piece of it. There is a clinical piece of it. And for us, because the way that we run our business is really important for our performance, for our reviews, for the way that people assess us, and for you, because I bet you're okay going home a little bit earlier from your hospital stay if we can be efficient, the operational side. So rather than just to make those stick in your brain, we're going to tell a little story. And I'm going to credit them fully because I came with a wonky lens on this, and they said, how about we turn this into a story, because stories are better. I think the story starts with research and with Girish.
Well, I think the story starts at the beginning of life, right? So
Oh boy, we didn't talk about this.
at creation. I'm joking. But I just became a father again around 9 months back. And one thing I realized, right, that you have all of this world, your work world, your friends world, your family, but when anything happens to your kids, all of your world just contract down to the kid, right? And I'm sure all of you feel that in some way, shape, or form, right? So the story starts with the neonatal intensive care unit, right? The sickest of the sick patients, the smallest of the small, the most vulnerable patients that are in these incubators. And because they're so small and they're premature, they have a high risk of developing a lot of things, and neurological injury is one of them. So there was a case that we read about where there was a baby in the NICU that had a spinal cord bleed, right? And the only symptom of that bleed was like a little twitch in the left leg. And I mean, you can't have a human being watching that baby 24/7, but even if you did, it was so subtle and so hard to point out with your own eyes, like the pattern was so subtle that they would have missed it, right? So that, where others see adversity, we see opportunity. So we decided to do something about it, right? And what we decided to do was put a small camera, like a $100 camera, in a baby's neonatal incubator and link that up with video AI, so you can have that baby monitored 24/7. I mean, video AI is kind of omnipresent right now. You drive a self-driving car, it uses video AI, right? You use Meta glasses, that's video AI, right? And the advantage of video AI, or AI in general, it doesn't get tired. It can miss small, subtle manifestations that the human eyes miss. And you can actually monitor that baby for 24 hours, 7 days, and you won't miss a thing. And we developed this video AI algorithm that can detect with like 95% accuracy 2 hours before any human can even detect it, if the baby is going to have a neurological insult. And I think that is one of the promises of AI. It's because that video AI is sort of an embedded knowledge, you can arbitrage that knowledge for time in which you can make a clinical decision and make an intervention and change the course of the whole life, right? And we talked a little bit about health span, and if you make these changes early in life, how the ripple effects across your health span probably are huge, right?
Because if you catch the spinal cord bleed, you can intervene on it.
Exactly,
Yeah.
and prevent paralysis and prevent neurological insults, right?
Yep.
And this was work done by Ben Glicksberg, who runs our children's AI, Center for Children AI. And I think, there's this paradox right now, right? That we do a lot of research, but it never gets implemented into clinical care. And, all happens is, you publish a paper and it looks nice, and but I think that what you said about the full thickness sort of resonates, right? Because you can take this research product and implement it into clinical care, and not just at Mount Sinai. You can take it to the FDA, get FDA breakthrough status for it, and implement it across NICUs around the country, because the vision should be, scale it at Mount Sinai, but implement it throughout the country so that no baby has to go this before.
So the idea comes from the clinical environment, gets turned into a research question. The Department of Artificial Intelligence, figures out how to. I like how Girish talks like, oh yeah, video AI. All of a sudden, it knows who's having a seizure or who might have a bleed.
Yeah.
In his mind, that's true. For the rest of us, we'll take your word for it. But then you got to implement, right?
Yeah, that's going to implement.
Yeah.
And that's when this partnerships and sort of this sort of whole spectrum translation works. So I'll turn it over to my colleague and friend, Robbie.
Thank you, Girish. And as a new parent, this is a use case that just resonates with me, thinking about how we can improve the life for our youngest patients. And so we've been focused on building out a competency to take things developed in the research lab and bring it from bench to bedside. And so one of the things that we've learned along the way is that as amazing as AI is, as amazing as the tech stack is, really the value gets unlocked in the human stack. And by that, I mean sitting down with our frontline team members, and we have a co-design process so that in this use case with the NICU, we can sit down with our physicians and nurses and co-design the AI product in a way that we can ensure it fits seamlessly in the workflow. And it's really important that we have that voice of the clinician when we build these products. We don't want something that's just handed down without the voice of our clinical teams. And that's helped ensure that when we implement these tools, we have adoption. And that we have the buy-in, because we also want to make sure that our clinicians understand the why of what we're doing, why we're doing it, and how this technology works. I think not doing it that way would be like building a plane but getting no feedback from the pilots. We want to make sure that we're getting feedback from the clinicians who are working on these tools. And so if we were to zoom out from there and think about kind of the broader perspective on how these tools are, what they look like across the hospital and across the system, I'll turn it over to my colleague, Nick, to talk about that.
Yeah, so I'm an emergency physician, but I kind of grew up as an operator and a medical director. And it's great when we have these things at the bedside, but what we're trying to do across the health system is to operate at scale. So we've got 7 hospitals, hundreds of clinics. We've got 2.1 million users of My Mount Sinai. We have a lot of data, right? So how do we get this information into the hands of people who can use it? So for instance, when we're running the NICU, how do we predict which of these patients has met the milestones to graduate out of that NICU? We've got 12 mothers that are laboring on the west side of Manhattan who are potentially going to need those beds. So we need that critical capacity to make sure we're caring for our sickest babies. How do we identify the bottlenecks in throughput of getting patients through the hospital? So we're really trying to design those things at the system level to really give information to our care teams to get patients through the system and get where they want to be, which is home, healthy, happy. And then when they get home, they encounter lots and lots of challenges, continuing to deal with the system on the back office side.
Right. And so, as Brendan said, we tend to think about our AI technologies from the bench. It starts with research, and as we develop those tools. There is a back office component, and I'll come back to that. And we're always focused on that patient at the bedside and the family that's caring for them. And so in this example of that newborn baby that ended up with a fairly serious condition and potentially dangerous consequences, we don't want our patients to have to deal with a lot of the administrative burden, right? There are bills that are going to come to the patient's home. Those bills need to be paid. Insurance companies are going to assess whether those claims should be paid for or not. There's a whole factory of work that's happening in the background, and not just on billing, but I'll just touch on that as the example. It's where we're also using artificial intelligence to streamline and simplify those processes so that our clinicians can focus on the patients and that our patients and families can focus on their own health and well-being, and that we're not forced to do a lot of manual work with phone calls to insurance companies, double-checking and triple-checking the criteria they have to cover, the individual procedures that we might have provided. And so always with that vision, bench through the back office to the bedside, with the patient at our focus, is how we are continually thinking about artificial intelligence. And all of the data that we are generating, from the clinical data that's coming from the laboratory tests and now what we're capturing through those cameras, the data on the billing and the claims, again, that full spectrum is allowing us to operate as that learning health system that Dr. Carr mentioned. Those data, as we generate them, are then funneling back into the research engine to allow us to continue to develop and improve care for the people that we're privileged to serve.
So those 4, right? I mean, just that story that, there's research, there's clinical, there's ops, there's the whole administrative backside. Those of you running businesses and working outside of healthcare that are interfacing with AI are saying, yeah, We've been using AI forever to make sure that our supply chain is as efficient as possible, to make sure that we're optimizing our performance, to make sure that we are, running our business as best as we can run our business. Sometimes that involves, reduction in workforce if you can create efficiencies. No one likes to talk about it, but it is something we need to talk about as time marches forward. And now, of course, it was the health session. There was a session on artificial intelligence and health, and there was a lot of talk about robots and what robots are going to be doing. So that's all out there, and that's all real. But we just wanted to sort of showcase with a story. So chapter 2 of our panel here are questions, because you should be saying it's your supply chain. You should have artificial intelligence helping, and you should even be saying to Nick, of course, you should be figuring out where the operational flow is non-laminar or is inefficient, and you should be getting some guidance from coaching tools and sort of from artificial intelligence to help you with that. But Lisa, you talk about the fact that the closer that we get to the patient, it becomes different, right? Like, yeah, we're a business on one hand, but on the other hand, we're a business that is in the business of people and their health, and that's an enormous responsibility for us to carry. So that distinction about how safe you feel when it's in the supply chain and how scared you are when it's at the bedside.
Yeah, I would say I am very cautiously optimistic, but that caution is critical. When human lives are at stake, we must take very deep care in assuring that the tools we deploy are safe and effective, right? If it is supposed to detect that small movement in that baby's leg and it misses it, we've deployed technology and not achieved the aim. But if it also does something else damaging to the baby that we didn't anticipate, that would also be a very bad consequence. And so we have to be very careful about that evaluation and really strive to balance the speed with which we can innovate and that safety and rigor that we need to apply to ensure we're doing it safely. And then the day that we deploy a tool is really the beginning of the ongoing work of monitoring it over time to ensure that nothing changes that we didn't anticipate. There's also a very interesting phenomenon I find particularly in healthcare where we tend as clinicians to hold the technology to a higher standard than we would try to hold any human. We want the technology to be perfect. I've literally had clinicians tell me if that device makes one mistake in our call center, we have to shut down the call center. I said, really? When our human agent makes one mistake, we don't shut down the call center. We retrain that person to do the right thing, and we make sure the patient has the right outcome. And so I think societally, thinking about that technology in the same way we think about a new trainee in the workforce is a really important structure that we need to put into place. Again, but balancing the goals we seek to achieve with the potential risk when human lives are at stake.
Yeah, so we'll talk about that training a little bit in a minute, but before we do, what are we afraid of? I mean, we're afraid of, sure, maybe something gets missed that a human would have caught, but we're also afraid of, and the language that gets used most often in the rest of the artificial intelligence world is hallucinations. The language that gets used in the Girish world is also hallucinations, he says. Yes, but really it's bias, right? He talks all the time as a scientist about bias and what that means. So hallucinations, bias, all this, for things that are running around in our clinical environment. Can you unpack that and talk about how we think about it?
Yeah. So I'll mention hallucinations first, right? So hallucinations is when a large language model or a chatbot generates factually wrong information. It makes up stuff. It hallucinates, right? And that's almost like a feature, not a bug, because chatbots are incentivized to complete the sentence, right? Just statistically what the next word is, and the word after that, and the word after that, and the word after that. There's no requirement that word be true. It just be statistically probable. And if you think about where chatbots are trained on the internet, people would argue that the internet is also lots of information, but lots of misinformation. So there's equal parts sort of information and misinformation in the mix, right? So yes, hallucinations can be mitigated to some extent by novel AI techniques, but this goes back to what Lisa was saying about assurance and monitoring. So assurance is like before you deploy anything, we want to stress test it to make under a variety of circumstances, under all of the circumstances that physicians, nurses, other providers can think of to see what the acceptable range of outcomes is, and then put like actual guardrails to make sure that that particular AI chatbot or agent or whatever you want to call it stays within those guardrails, right? Because guardrails and frameworks are critically important for that. Monitoring is, once you've deployed it, you want to make sure that at regular intervals, and those intervals change depending upon what risk it is, right? If something that's patient-facing, treatment depends on it. You want to monitor it more frequently than something that's maybe operational, right? But at regular intervals, you go back and you do that stress testing and you make sure that it hasn't fallen off the rails for lack of a better
So it has to
word.
get trained, and then you can deploy it, and you got to track it, and you don't want it to hallucinate.
Yep.
But you left out the favorite word that you talk to me about all the time, which is bias.
I was coming to that.
All right, fair enough.
Bias is when an algorithm performs differently in different subgroups based upon just demographic subgroups, right? So there's a famous example of bias in which a large electronic health record company, shall not be named, it trained an algorithm on sepsis, like, an infection,
Bloodstream infection.
bloodstream infection, and, a lot of places around the country used it, and when someone actually did assurance on it, the accuracy of that was 50%.
Much lower.
flip.
Much lower than it had been when it was, rolled out and when it was
Yeah.
created.
Much lower than it was rolled out and created. And this was actually used in clinical care, right? So as you know, as a practicing emergency room physician, I don't know how many patients got undertreated, overtreated, not treated at all.
Yeah, you hope
because
that it
of
was an adjunct and that the doctor caught it or the nurse, the
Yeah.
team caught it. But the whole point of putting it there
was to be
was to
measured.
help you.
Yeah.
Yeah.
And then there's also bias in large language models because there's bias in the data. And that's where stress testing comes into effect, because you can take the same clinical case, just change the socio-demographic parameters a little bit, and see if the large language models gives like clinical suggestions that are different from what would be accepted from clinical guidelines versus like the actual norms. We had a paper recently that actually did that, and I think that's going to be standard of care for stress testing this large language.
And I guess I would just say it's one more place that, it is, I told you about the ethos of an academic medical center. This is how we think, this is how we function. We are increasingly saying to entities that need to validate, would you like to validate in our environment? We will help you. We have a lot of data. We don't want you to roll something out that was developed perhaps in a population that is very similar, right? And ours is very diverse, and all of a sudden it doesn't work as well. So, this will happen over time.
Can I build on that a little bit? So in that example of that bloodstream infection tool, what we learned, it was surprising. It seemed to work incredibly well in some areas of the country. It didn't work for us. And what we determined was that the model was built using data from a population of patients that was predominantly Caucasian. And when it was then applied to a very ethnically diverse population of patients,
New York City.
in New York City,
yeah.
the model didn't work as well. And so there was no intentional neglect or negligence, but it underscored the importance of assuring that the data on which we train models needs to represent the population of patients in which we're going to deploy it. And so if we were only ever going to use that model in a primarily Caucasian population, it would work fine. But deploying it to a different population, it needed to be trained on a different data set, right? And we've heard a few sessions that I attended even today, right, where women's health needs to be managed in a different way. And if we train our models on predominantly male populations and try to apply them to females, we're going to run into those same issues.
Yeah,
so
it's a story you've
that
heard
bias is critical.
Sorry. It's a story you've heard before, right? I mean, the pharmaceutical industry forever excluded men, and it's not. We know that it's there, and we have to think about. Did I say men? Excluded women. Yeah, and we know that it's there, and we have to be thoughtful about it as we roll it out. But let's pivot just a little bit and sort of say. So Robbie runs our digital strategy. And consumerism, it turns out, people are very sophisticated consumers these days. We are very, very special because we're health, and also we're very, very similar to everything else. And when you can get your reservation at a restaurant in a couple seconds on your phone, you expect to be able to do the same for healthcare. All right, so Robbie, you want to talk a little bit about the digital strategy, about consumerism, what that journey's been like?
Yeah, I think one thing that sounds really obvious but actually is not kind of seen everywhere is really having this experience-led model. And what that means for us is always being out there listening. So we do focus groups in the communities with our patients, with consumers who may not get their care at our organization, to really hear about what are their pain points along their health journey. So one example of a pain point that was coming up frequently was that when patients started having symptoms, they weren't quite sure where to go, because you can call your primary care doctor if you have one. In New York City, not everyone does. You can go to an urgent care, you can go to an ED, you can do a video visit, the list goes on. And so we took that feedback and we turned it into a digital product that we call Check Symptoms and Get Care. And with that, we use AI where patients can enter their symptoms, and the AI helps us match those symptoms with evidence-based protocols so we can guide patients to the right place and have them be in the driver's seat for where they want to get their care, and do that in a way that's really seamless. So in one click, you can get in the queue to see one of our emergency medicine physicians, or you can book your same-day appointment, or when it's needed, you can let us know you're on your way to one of our urgent cares. And so this idea of always being out there listening, I think it ties into the learning healthcare concept, that we're always learning, we're always talking to our patients, and we're there with their voice, we're able to design solutions that can help address the most pressing needs.
And I think just what we've seen in this is like getting to a joyful or delightful experience in healthcare, which seems impossible right now. Like nobody goes to the doctor's like, that was amazing. But that's what we're seeing with these digital tools. People say, wow, you built this with me in mind. Thank you for doing this. We're getting that feedback all the time now on these digital tools where we're meeting people where we're at. And that's what we want to do. We don't want to be this sort of difficult thing to access. We want to be where people want us.
So I'll tell a story and then ask Nick a question, which is, we have met with a bunch of different, so we're developing our own things. We also recognize that the rest of the world is developing things. And we met, these guys know well that I went to go get an early peek at a company that we knew about because they were running a health-related product. But and it was a 4-hour, very small session, and they were demoing their most recent product, which essentially was, although they labeled it differently, a virtual doctor. And I admittedly didn't know how close we were, and walked out speechless, called my wife, who's a primary care pediatrician, and said, you're out of a job.
You're done.
Yeah. And she said, tell me more, right? And so we talked it through. We asked them to come back to New York and to meet with our team and to talk with them. And so we have the decisions that we will make moving forward are really about sort of, as Lisa was talking, I was thinking, like, I wonder if there are any malpractice folks in the audience, because the degree to which you need to be certain if you're an individual, right, who builds trust and relationship with a patient who will forgive you. I have made mistakes, right? I've practiced medicine for decades. I've made mistakes, and I've apologized to people for making mistakes. Versus an agent that we expect to be perfect is really interesting. So we have ethical questions to think about, lots of them. We have logistical questions to think about. We have workforce questions to think about. What you guys hear this when you listen, to people talking about artificial intelligence. We know how massive the shift is that's coming, and we know that healthcare is going to be rolled up in it. But let me give you a very quick vision in the form of asking Nick a question about, here's what we think. This is where we think we're going, and this is what we talked about the other day as a part of the health panel, is that we have about 300,000 or so, thank you, Girish is central to it, 300,000 or so sets of folks' genomes mapped. We have all of your electronic medical record data, right? Because you come and interact with us. You open up the app, My Mount Sinai. We type notes about you. We have your imaging studies. It's all in there. If you'll give it to us, we know a lot about you because you self-monitor. You take pictures of your food, right? Your phone knows how many steps you take. Your watch knows everything about you. We have... he's probably wearing one, this guy over here, a wristband that you can wear that tells you what you're exposed to, right? We know based on where your phone, so what's in the air, that you're exposed to. We know based on where your phone is, which is where you are, what water you're drinking, what air you're breathing, right? This is your exposure data. And increasingly, we know all the little proxy things in your blood that we don't really talk about very much because we don't know how to use them. But it's just, you can imagine, hundreds and hundreds of metabolites and other things that exist in your blood. We are starting to be at the place where, so for up until now, it has been nearly impossible for us to do anything with all that information, right? We couldn't synthesize. It was information. It was not knowledge, right? And now, oh my goodness, the ability to process. So Nick's going to tell us, what, are we 2 months away from that? 3 months? No.
Yeah, with this team,
we're
a couple
not
months.
2 or 3 months away from that.
Yeah, I mean, and look, the human brain cannot make these connections. And what I'm here to say, we have to say something a little provocative. Like, you don't want to be going to the health system that isn't leveraging AI. You want to be going to the health system that is leveraging all these tools to give you actionable, personalized insights on your care. Now, that requires you to opt in. That requires you to say, all right, I can't send it from this whole thing, but from my Garmin or whatever, I'm going to opt in to sharing my information. When I go get a blood draw, I'm going to opt into Mount Sinai Million or whatever the genomic database is at your local health system. In order to get those actionable insights, you've got to be participating in this, but the human brain is not going to do this. And that's unfortunate for the way that we were trained as clinicians, just crammed information into my brain, and that was my value that I brought to the game of the clinician-patient interaction. That's not true anymore. We have so many tools that make my brain so much stronger and better for you. So you want to be getting care at the health system that's integrating this information, providing actionable insights, and then serving it up to the clinician at the time of care provision so that they know what you need.
So part of what I just heard, and I'll ask Robbie, because this is actually, round 3. The buzzwords that these guys say all the time that I know is always going to come out of their mouth, so I might as well ask. Right, Robbie, you reframe it for me, and you talk about AI as just one more member of our team, right? We have big teams, right? Some of us are docs, some of us are nurses, some of us are, are expert at analyzing data.
That's right.
Some of us are pharmacists. Oh my God, I did it again. Some of us are pharmacists, but now we have a new member of the team.
That's right. Yeah, in many ways, AI is one of the newest members of the care team, and it's certainly true that as time goes on, we're going to see more of these co-pilots. They're going to help you at work. They're going to help you, do your job and get things done. And so I think it's going to open up all new things for us to think about when it comes to the workforce. How do we build trust in these tools? We know that kind of many entities out there are nervous about what does this mean for the ways that we work. And so part of the way that we build trust is being really clear around our standards for safety and for assurance. And so that members of our health system really know that any AI tool that we roll out, and especially any AI tool that's related to clinical care, is going to go through the highest levels of assurance and the highest levels of safety and testing. And that's one way we'll start to build trust. One of the things we've learned over time is that when you can kind of get under the hood and show a little bit of the explainability of the model, that's really helpful for building trust with our care team. So an example of that is we have a model that predicts patients who may end up with a pressure injury or bed sore. And one of the things we do is we show our nurses and our doctors the top 10 reasons that patient's at risk. And so that helps build trust because you can have explainability and kind of understand what are the risk factors that are going into that tool. So I think we're going to have to make sure we can explain what's happening under the hood. And we have to make sure we're telling the story of how we test these things, vigorously and ensure that we have the highest level of safety standards.
Yeah, so I want to talk about testing and training, but first I want to say let's use another example over there, which is many of you probably have you've been in or you have friends who've been in a clinical trial. How do you get access to a clinical trial, right? You got to know the right people. Someone's going to refer you. I have to be aware when I see you of a trial that's happening, and maybe it's happening in my hospital, maybe not, maybe it's happening at the hospital around the corner, and then I got to know who to call. This idea that this information is now being surfaced, and it says, Girish is eligible for these 3 trials. We understand that he's got this type of problem, and these people are all looking at it. Girish has no problems. He's perfect.
He's perfect.
Yeah, and it surfaces it, makes it easy for that, right? So these are ways that we should just be thinking about, and that we are using the new technology. But the new technology, I'm going to come back to. We talked before. Sometimes I think we said sometimes AI can have biases, but sometimes people can have biases.
Absolutely.
Yeah, right. Sometimes med students can hallucinate. Sometimes, So the idea that what we do for a living is train people, right? And now Robbie just said we have a new member of the team. That's how we think about it. We have a new member of the team that we are training, and that's our job. And I'll tell you, when med students arrive to us, they are not the same as when we graduate them. as a physician. And when residents arrive to us, they're not the same on day one than when we set them free range into the world to take care of you and me and my loved ones and my parents, right? We train for a living, and training artificial intelligence is a natural fit for us.
Oh, absolutely. So I think AI is really smart, but also very dumb, right?
Yeah.
I mean, it's really smart because it has all of the encoded knowledge of the world, but it's really dumb because it needs guidance and it needs context to how to tackle the patient in front of them. And that is going to lead to this whole new area of human AI collaboration, like AI being a member of the care team, but humans sort of learning in collaboration with AI and each getting better, right? And like having unique aspects of the overall holistic care across the health span that some, humans are good at, and then there are these parts that AI is good at, surfacing, sort of distilling all of this information and surfacing at the point of care, and then humans will be, better at it for their jobs, right? So I think we are entering a whole world of like human AI collaboration where, we have to rethink how we train med students, and we are doing that because one of the ways to do that is to give access to ChatGPT
Yep.
or things in a secure environment so that they can learn how to interact with AI, what they are good at, what AI is good at, but also sort of experiential learning programs that, over the course of how they sort of mature and how they graduate, sort of how to make them much more skilled practitioners of their craft by using AI as a member of their care team, right?
Yeah, Deepak Chopra the other night called it meta-humans. That's what we will be in 10 years. He said we will be meta-humans. He also said, by the way, that hallucinations were good in a lot of ways inside of artificial intelligence because it was, because it allowed us to, to explore places that we might not have otherwise explored. But I referenced before that we build a lot of things in-house, but we don't believe that we should be building everything in-house. We believe there's amazing opportunity for partnership out there. So, the NIC buzzword is always going to be about partnerships and about external collaboration and about all the venture funds that have created AI solutions and all the firms that don't hear this wrong if you're a patient, that need a laboratory. I don't mean that in some terrible way, but they need access to patients. They need us to give them access to our patients to say, if, does this help to change your behavior, to change your outcome? This is, you don't think when we're doing a drug trial of you as a lab, right, as a health system, as a laboratory, but that is what it is, right? We're experimenting in a very controlled, intentional way with consent. But the external entities, all these firms are out there, they don't have our patients or the trust that we have with our patients.
Right, and that's what we're so excited about at this inflection point. We know that we can't build everything. We know that Silicon Valley and Silicon Alley in New York are building exciting tools for us to bring into the health system. We want to be that partner. We know that health systems were not the best places to sell into. We want to be able to receive those tools and get them to our patients, frankly, and deliver an amazing patient experience. But we will be protective of the brand that has been built. What really matters to us is the trust that has been built with patients over the last few decades. That matters more to us than anything. So we will hold those external entities to high standards. But we really do want to partner and recognize that we're not going to be as good, say, on the user interface side and the user experience side, where things can be kind of clunky inside of an academic health system. But we're going to hold people to the standard of we're going to use our enterprise tools where we want you to be interacting with our electronic health record. We don't want patients to be using multiple apps. We want them to have one portal of entry for all of their health span related needs. So that's sort of the standard that we're going to hold people to.
Yeah, and the docs, and the providers. It's got to be user friendly for them. We can't just pile more and more work onto their shoulders. So we have a minute and a half before we're done. So keep it tight. But what's the one takeaway that that you want people to resonate with? Maybe I'll pick Lisa.
Yeah, I hope you all walk away with that sense of hope and a vision that we are leveraging technology, data, artificial intelligence to understand the human condition and health and to improve it over time. And that there is a tremendous team effort, again, from that bench through the bedside, from our researchers, our caregivers, and you all as our consumers, patients, and families are an incredibly important part of that learning health system that is going to allow us to do that. And that our future is not simply something we enter, it is something we create, whether it's through those partnerships, through the research, or through the vision that we collectively establish around what healthcare needs to look like for our personal benefit.
One more of you, something burning to say to close before we go to questions. You got one burning?
Just like get engaged, like use the tools, ask your doctors and your providers how they're using AI right now. You should know what's going on, and they should know what's going on, and if they don't, maybe look around.
Ouch. Oh, and with that, I imagine there's a microphone in the back here, and I will, oh, you want me to call somebody? Have it right in the back here, sorry. I was giving her all control.
Thank you. I know over recent years how AI has really benefited healthcare by being able to identify helping with diseases that would take years to solve. Are you thinking that this is going to enhance where surgeries or just even solving situations it will enhance, or are you thinking in the future this is going to replace? Are we going to walk into an exam room and, it's not going to be a human, or how far is this, the projection?
You can say the word robot. It's okay. Karen DeSalvo said it. She Google Health and used to work in the federal government she was national coordinator for health IT. She says the word robot a lot. How about, I'm happy to have anyone take this. I'll get, Lisa's got chomp at the bit.
Yeah. We firmly believe that it is a collaboration between the AI agent or robot and the human, and that we do sometimes fear becoming obsolete, that the robots are going to replace this very human work that we do. The power in it is truly in that collaboration of AI plus human that unleashes the full potential of both. And so, we touched on it. Doctors aren't going to be replaced by AI, but the doctors who don't use AI will be replaced by those who do.
We'll jump. How about right here?
Hi, thanks for this. So I heard earlier today somebody said that the U.S. innovates and the EU regulates. So EU AI Act goes into effect in August. Colorado has local legislation for regulating AI, so does California. There's a whole debate right now in the big, beautiful bill around federal regulation. As a research institution, how are you blending innovation, regulation, and then patient care and life or death in the middle? Obviously, it's very different if you're building an AI model for payroll, but very different as you're thinking about regulation for patient safety.
Yeah, absolutely.
I'm glad I don't have to answer this one.
No,
Good.
I'll take it.
All right, good. Ooh, Girish is unafraid of you.
So I think that governance and regulation doesn't have to compete with innovation. I think if your goal of innovation is to move things from the bench to the bedside, but you have to do that in a safe, effective, ethical, responsible manner, right? And that's why governance helps, because that's why assurance helps, because you can be sure that at least, and monitoring helps, because you can be sure that the things that you're translating into clinical care, be they from a vendor, be they developed in-house, are, they are first of all safe, that they won't cause any harm. They are effective, right? Which
It's okay.
I did not do that.
There's a shaken soda or something. Everybody's okay.
That they are effective, that means that they are actually doing what they're supposed to do, and you can measure it. And they are ethical, that means that there is no bias and there's no hallucinations, right? So thanks to Lisa and Robbie and Nick, we have like a streamlined governance structure which stratifies, first of all, the risk of failure, right? Like, for example, the risk of where a clinical model failing is much higher than the risk of a back office model failing, right? The risk to failure. And then, depending upon that, every model of that goes through assurance, both at point of care and longitudinal monitoring, and then only it gets deployed. And after it gets deployed, it's just a start, so that you do this. So my point is, I think good governance is central to good innovation, because that's the way that you don't get into trouble, but B, I think that's the way that you keep your patients safe, but also give them effective treatments.
I also think, and I'm less informed here, but that as long as the human is in the loop and it's advisory, that's one piece. I'm guessing your question is about when we're ready to, cross that or jump that what did Fonzie jump? Yeah, right. At some point, jump the shark. That's where Fonzie jumps, right? When we get to that place, we're going to let it be autonomous.
Right.
And that's where the regulatory piece is going to be really hard.
Yeah.
In the back over here. She's right. She's almost there.
Do you have any indication what percentage of your patients are willing to provide their data? And how large do you think the databases will become?
Yeah.
I mean, is it going to be Mount Sinai's and other health systems combining, or is it going to become national systems?
It's a great question. You want to talk about one, Mount Sinai million, two, hyperspace, or Cosmos rather?
Yeah, I can start with the portion you asked. Are health systems essentially combining their data with other health systems? And that answer is yes. So there are several of these collaborations across the country. One administered through one of the large electronic health record companies, where individual clients of that EHR have the ability to add their data to actually an international collection of patient data, and there are a few other collaboratives in the U.S. We think that is important, right? So all the things we talked about, you can make a model better, right? Assure its safety and efficacy when you've got a diverse data set on which to train it, and so combining the data is a really important piece.
De-identified when it goes in?
De-identified, yes, when it goes in, yes. So that we're training the model without implicating any individual patient.
And the example that you've used in the past is rare diseases.
Yeah, so you think about some very rare conditions. The ability for any one health system who might see one patient or none, right, depending upon where the health system is situated, the ability to not only research it because of the larger data set, but for that local physician who's caring for you where you are to find other clinicians who are caring for similar patients, to talk about that, share their best practices, connect patients and families who are dealing with that rare condition is also in the power of those data. To your question about how many of our patients are contributing their data, yeah, the majority of our patients are willing to contribute those data, and we are grateful for that, and we take that obligation very seriously to be very conscious stewards of the privacy and the appropriate use of those data.
I would say even their genetic, I don't know what data you meant, but even their genetic data, there's an initiative at Sinai, it's sort of unrelated to AI, except that of course we will use AI to analyze it once we have it. There's a large initiative at Mount Sinai to collect and genotype 1 million patients, the Mount Sinai million. And so for us, as you think about the brief conversation we had around stitching together all the information about you, the foundational piece is your genetic makeup, and people opt in. Do you know the number?
Yeah, 50% of people opt in for that.
There you go. So 50 for your genetic data. Tethered to your electronic medical record, or
Tethered to electronic medical, all electronic data.
But you can imagine the stories that we could tell about an actionable gene that was discovered, right? That transformed somebody's life. Look, the privacy stuff, it's scary. And when we think about insurance companies, life insurance denying you because of something that's in your genetic code that's now tethered to your electronic medical record, it's all real. And these are important ethical conversations to sort. There was one over here. Yes, ma'am. Right behind you, almost there.
Thank you. I was so glad you all brought up just now the rare and genetic diseases. I do a podcast on rare and genetic diseases and medical challenges, and I find that many times you're also talking neonatal infants and children are often showing the signs of rare and genetic diseases at a very early age, but not all the doctors can identify what these conditions are. They don't even know them. They're too rare. So to what extent, following up on what you were talking about, will AI anywhere within the next 10 years be able to have a group database help to identify red flag and identify rare diseases that hospitals and doctors around the country may never have heard of?
Yes.
Yes.
No, someone elaborate.
So I would argue that AI can actually do that now because AI is great at subtle pattern spotting, right? So just from my
and that's what it is. It's pattern recognition. Yeah, right? Sorry to interrupt.
Yeah, no. So just from my own work in neonates, you can identify a rare apnea of prematurity in neonates with like 95% accuracy. You can identify rare genetic conditions with like 90% accuracy. With the Mount Sinai Million Health Discoveries program that Brendan alluded to, run by Alex Charney, we are now also sequencing neonates and children at birth so that you can actually have genetic confirmed diagnosis that can be used to train further and better AI using multimodal data streams, be they video, electronic health records, monitors, et cetera, et cetera. So it's happening now.
We aren't there yet.
We are not there yet.
But you said 5 to 10 years.
Or 2 to 5. Yeah.
You asked 5 to 10. Girish said 2 to 5. He put his nickel down. No, it's okay. Any others? There was one in the back here. Sorry, sir. I'll get you next. I may not get you next. I'm sorry.
I should probably say I'm an old, white-haired, now retired clinician.
Yeah.
But I have two comments. One, I hate the term artificial intelligence, which has been around for a while, because that implies to many people, especially those lay population, that it's smart. This is intelligence as in information, and I don't think we've made that distinction very well so that people can have a better idea as to how this could really apply to what we're doing. I think that's
fair.
Perhaps a fun.
We could focus on a pivot.
Idea.
Okay.
Yeah.
My other comment is just, as this develops, and you guys are obviously doing a great job with this, there can be a point where people start to stop using this as a tool and say, well, it told me what to do this, so I'm going to believe it.
Yeah.
And I think that's a dicey kind of decision point, and how do you approach that?
Yeah, well, the session on how to raise kids in the world of artificial intelligence on the hall. It's yes, of course, and I know that it's a question that we will stammer and stutter to answer. It's also our responsibility, right? I mean, how do I, teach my children in high school and college not to let ChatGPT write their papers,
Right.
Or to not summarize the whole book for them, because there's really something magic about reading the actual book, right? Yeah, the answer is multifactorial and complex, and very much on our mind as we train the next generation of clinicians. That part will promise you. How successful we'll be, we will know in time. Thank you, everybody, for being here. Thanks, Aspen, for letting us be here.